Okay, I think we can get started on housekeeping items. Good morning, everyone, or good afternoon, or good evening, wherever you're joining us from. Welcome. My name is Hadi Khan. I am both an internal medicine physician and a palliative care physician here at Massachusetts General Hospital and on faculty at Harvard Medical School. I am a member of our program in global palliative care, and on behalf of all of our program members, I'd like to welcome you to our palliative care lecture series. This is about the fourth installment now, since our program was started about a year ago. And this platform is really dedicated to discussing topics related to the development of palliative care in resource-limited settings. This includes research, program building, education, policy making, and contextualization. And today we are joined by members from different organizations to talk about a very, very important and also ever-vexing problem, which is safe access to morphine for medical use in resource-limited settings. Without further ado, I'll turn it over to Dr. Eric Krakauer, our program director, and he'll be leading and moderating today's session. Thank you.
Thanks so much, Dr. Khan. And welcome, everyone. I see colleagues and friends from around the world. This is a very important session. It's the last one of the academic year, and there could be it's hard to imagine a more important topic. The title, Insufferable Pain, What Prevents Safe Access to Morphine in Low-Income Settings, and How Can the Barriers Be Overcome? So unnecessary suffering on a massive scale persists in low and middle income countries due to lack of safe access to opioid analgesics, like morphine especially. This morally and medically egregious problem has proven difficult to solve for a variety of complex reasons. Historically, there's been a historically determined fear of opioids and antipathy to opioids related to their use by the European colonial powers as means of supporting colonial regimes and oppressing the colonized. There have also, partly as a result of this history, highly restrictive laws and regulations around the world on opioid prescribing, some of them left over from the colonial era. There's a lack of education on opioid analgesia, and even in teaching of incorrect information about opioids, especially about side effects. Then there's a reluctance of doctors to prescribe opioids, even where prescribing is permitted. There's a failure or inability of many countries, hospitals, and pharmacies to stock opioids or to avoid stockouts, and there are difficulties for low middle income countries to obtain and safely handle and store opioids. So many problems, many barriers to getting the appropriate pain medicine, the appropriate opioid, usually morphine in low-income settings, to the patients who need it. The most important global agreement on controlled medicines, the 1961 Single Convention on Narcotic Drugs, which was signed by virtually every country in the world, emphasizes the idea of balance, and I will insist on this term, balance in national controlled medicine policies. That means there should be equally strong efforts to maximize accessibility of opioids for medical uses, such as pain relief, and equally strong efforts to minimize the risk of diversion of opioids to non-medical uses. But as we know, around the world, a lot of effort focuses on minimizing risk of diversion and far too little toward maximizing access. So balance has been an elusive goal. To better understand this problem complex and to seek solutions, we've organized this seminar with representatives of 3 United Nations agencies who are global leaders in the most important aspects of opioid policy and safe accessibility. We'll hear about the most important barriers to safe opioid access and how to overcome them from their perspectives. We'll then have a panel discussion, and we hope that this seminar will promote more intensive ongoing collaboration between the UN agencies and other stakeholders to find solutions to the current medically and morally unacceptable situation. So our first speaker from the International Narcotics Control Board is Professor Zukisa Zingela. Professor Zingela is Executive Dean of the Faculty of Health Sciences at Nelson Mandela University in South Africa and former chair of the Department of Psychiatry and Behavioral Sciences at Nelson Mandela Academic Hospital and Walter Sisulu University. She holds a number of leadership positions nationally and internationally, which includes serving as the second vice president of the International Narcotics Control Board and chair, which is abbreviated INCB, International Narcotics Control Board, and chair of the INCB Standing Committee on Estimates. The International Narcotics Control Board is a UN agency based at the UN city in Vienna, Austria, which has very pivotal role in access to controlled medicines, particularly opioids. Professor Zingela holds a Bachelor of Medicine and Surgery from the University of KwaZulu-Natal, a Master's in Psychology from the University of Pretoria, a Fellowship of the College of Psychiatrists of South Africa, and a PhD in Psychology from Nelson Mandela University. Her research interests include substance use disorders, traditional medicine and mental health, healthcare worker mental health, and public mental health. Professor Zingela, thank you so much for honoring us with your presence. Please.
Thank you so much, and I must extend a word of gratefulness for allowing me to be part of this really critical discussion. So, without further ado, then I will first send out my greetings to everybody who is attending currently, and to also then wish that everybody who is attending will be able to take part in this critical discussion in a way that moves us forward. So first of all, we've already indicated what the role of the International Narcotics Control Board is when it comes to this really critical subject that we're discussing. And it is important to know that in the functions that we do as the board, we are guided by the three conventions, the three United Nations conventions, the single convention on narcotic drugs of 1961. We then have the 1971 Convention on Psychotropic Substances. And lastly, we've got the 1988 Convention, which then focuses on prevention of diversion. So the INCB has in the convention some very specific mandates, which also include ensuring adequate availability of narcotic drugs for medical and scientific purposes, and at the same time achieving that balance that we've already referred to prevent the possible diversion and abuse. In the process of carrying out these functions, we carry the responsibilities of monitoring and promoting compliance with the drug conventions and treaties, ensuring the availability of controlled substances for medical and scientific purposes, and also monitoring availability, cultivation, production, import, export, consumption of controlled substances, and the like. So to assist member states and countries and also working along with WHO, we then provide guidance on how to properly estimate the country needs. And we used three methods which we are willing to share today. The first one is looking at previous consumption. And the next one is to also assess the needs from health services based on information from people on the ground who work in the health services. And this, of course, has to be based on evidence and statistics. It is also possible to use more than one method in order to have a better estimate of needs. And the reality is that 75% of the countries use the past consumption method, and only 25% of them use the demands of the health service as well in conjunction, which obviously then would leave us a little bit on the back foot as member states if we then want to capture the real need of what the citizens need in the country. Thus, this means that the estimates submitted to the board are based on limited indicators of past consumption, and it does not take into account, for example, changes in the demand or the service. It's, of course, a big problem in that it impacts considerably then on the availability of opioid analgesics globally, especially in the countries which tended to have lower consumption to begin with. So since the publication of the INCB's first report on availability of controlled substances for medical purposes back in 1989, the board, together with its partners, has continuously called for more attention to ensuring availability of and access to medicines containing controlled substances, especially taking into account feedback then from the service point and the service users who would then guide as well the current needs in each member state. Several decades of data have shown us that there has been an increase in the reported consumption of opioid analgesics, but what does concern us is that the gap between high and low, as well as middle income countries, remains. And we have seen an increase in the use of synthetic opioids, particularly in high income countries, but affordable morphine consumption has not increased as needed in the low to middle income countries, which I think is also one of the reasons we are very pleased about today's panel. Most of the morphine produced globally is not utilized for palliative care, and the small portion that is used for palliative care is again consumed mostly in the same high income countries. The colleague from WHO will be able to show us graphs based on INCB data, and manufacture of morphine in 2022 was over, this is now an example that manufacture of morphine in 2022 was over 218 tons, for example. And then what we saw was the total quantity utilized in terms of consumption was even more at 257 tons, including stocks.
Excuse me, Dr. Professor Zingela, I'm so sorry to interrupt. If the slides were supposed to be advancing, we're not seeing them. We're only...
Oh, yes. I'm so sorry. Yes, they are supposed to be advancing. I'm terribly sorry about that. Yes, they're supposed to be advancing. So I'm going to guide. Yes, let's continue. And I think it's going to be around slide 6 that we are talking about. Yes, I think this is, if go back to that, yes, this one. So this one basically tells us the tons, in terms of production of morphine and its utilization. And you'll see that the figures I was referring to then are indicated here as well. And my apologies for that. I actually didn't note that the slides were not advancing. So what this then tells us is that as much as there is a significant production of morphine and related substances in terms of meeting the global need, when we look at distribution of the produced controlled substances specifically for pain management, however, we see that it is not equitable, with low to middle income countries then not getting the benefit that one would expect given the amount that is produced. And an example is that only 33 tons were consumed directly for palliative care, but over 28 tons of 86% were consumed by specifically these countries, which are high income countries, the USA, United Kingdom, Austria, Canada, and so on, which means that all high income countries have managed to benefit from this production, and low income countries were left with only 129 kilograms, to use. Shall we advance to the next slide, please? So in general, what we are then saying is that long term, we have seen that the average consumption in the years 1998 to 2000 has shown us this picture that we're seeing now. Red indicates high level consumption over 10,000 daily doses per million inhabitants. And this can be seen manifesting as a pattern only in the USA. The rest of the map of the world shows us that there is less consumption in many other parts of the world. And you will see that if you look at, for example, some regions in Africa, some regions in South America, and some regions in Asia, you'll see that consumption is far less, at anything ranging from 1,001 to 2,000, or even less at times than 100, which of course is of concern. Let's move to the next slide, please. If you then look at the global trends, 2008 onwards, you also see something similar, where the area of consumption that is the highest is again indicated in red. And you'll see that the majority of low to middle income countries are also again reflecting relatively low consumption, which is of concern, as I've indicated. Next slide, please. Similar, global trends are shown here. So generally, if you then, take these last few slides, it gives you a very, unequal picture of distribution and availability of pain medication, specifically medication that is controlled internationally. And it therefore says to us, we cannot imagine that people who need this medication in the low and middle income countries are able to access it when they need it. It therefore calls for urgent action in terms of what we need to be doing to address this. Next slide, please. Similarly, here you'll find that when we look at global consumption of opioids for pain management for the period 2003 to 2022, again, we see, if you take the individual substances, fentanyl is the highest in terms of what is reflected in the graph. And then we've got other substances which are also used, but much less so. That includes oxycodone, it includes morphine, it includes hydrocodone, codeine, and hydromorphine. And over the years, we have seen an increase, which it has remained marked in terms of fentanyl compared to the other medications. And even this does also tell us that we're still facing, different challenges depending which country we're in, but in general, the common thread is that, low and middle income countries are not getting access the way they should be. Next slide, please. So if you then look at the distribution of the different countries who are gaining access to the painkillers, you will see that, again, North America comes out highest, followed by followed by Western Europe. And, in general, if you then go to countries like West Asia, Central America and the Caribbean, and you also look at Africa, you'll find that we tend to see a pattern which is repeated, if one looks at the previous slides that we took you through. So in general, what we're finding, next slide, please, is that despite the support and guidance that the board has been providing, we seem to be lagging behind globally in meeting these needs. And one of the areas that the board has really worked hard at is to try and set up a set of guidelines to support, but also increase consumption in countries which show a dramatically low increase, consumption, excuse me. And, I'm going to be taking us through the different recommendations that the board has then made to try and improve availability and access. But what you're finding is that in the following graphs, it is the same message that we're seeing over and over and over again. And that is, you've got high income countries, which are the largest consumers of these medications. And then you've got low middle income countries and regions, which are generally not benefiting from access as much as one would if one is looking at equitable access. So what I'd like us to do now is, please move to the slide where we're talking about recommendations. And this is in view of the time limits that we need to be very aware of. Thank you very much. So if you then look at what the INCB is proposing, we are proposing something that has already been shared with a number of competent authorities and member states, but we want to reiterate this message, especially because we're not seeing as great an improvement as one would have liked in availability and accessibility. So the first one is to ensure that national and or regional production of pharmaceuticals to improve access and affordability, it receives top priority. And this is done with cooperation of pharmaceutical industries. We are also advising that consideration should be given to banning the advertising of controlled substances under international control. This is then in view of the attempt to balance, ensuring availability and accessibility while limiting diversion. We also greatly urge countries to train health professionals on palliative care and to ensure that this is available at point of care so that people don't have to travel long distances to access palliative care. We also encourage countries to submit estimates that are based not only on previous consumption, but also on the country's medical needs, which include palliative care. And we also encourage facilitation of import and export authorizations, which of course we support as a board through a web-based platform, which is called the I2ES. And then in addition, we recommend that more healthcare professionals should be able to prescribe and administer these controlled substances and painkillers. And then there is the need to train health professionals in the use and rational prescribing of controlled substances to ensure prescriptions that are appropriate to the needs of patients. We also encourage that governments should mitigate the legal sanctions applicable in the case of unintentional errors because they limit the ability of health professionals to prescribe. And then the board also encourages governments to increase the availability of low-cost palliative care services to patients to ensure better access. And then lastly, we also encourage that public health policy should prioritize the issuing of licenses for the manufacture, import, and export of essential medicines. Thank you very much. Oh, thank you. There is a comment that says that the slides, again, were a bit behind in terms of recommendations. On the plus side, however, is the fact that we will also be able to share these slides with everybody who has attended this session. And I would then encourage everybody to also engage further with the slides offline. So thank you very much.
Thank you so much, Dr. Zingela. That was for this fabulous presentation and setting the dismal scene of the global access to opioids. And you know what I hope that the audience can appreciate in those graphs and those numbers is the sea of suffering and the terrible suffering that patients are going through for lack of access to safe, effective medicines. Our next speaker, Dr. Elizabeth Sáenz Miranda, is from the UN Office of Drugs and Crime. And this is a particularly important UN organization, particularly because for policies to enable access to opioids, to enable physicians to prescribe without fear. The ministries of police are extremely important and need to intend to be more powerful than ministries of health. And there needs to be an acceptance that pain relief is crucial also in ministries of police. And the ministries of police tend to listen to the United Nations Office of Drugs and Crime. Dr. Elizabeth Sáenz is from the UN Office of Drugs and Crime. She's a pediatrician who also holds master's degrees in public health in developing countries and in maternal and child health from the London School of Hygiene and Tropical Medicine and the University College London, respectively. Originally from Venezuela, Dr. Sáenz has worked in several United Nations organizations, including the Pan American Health Organization, or PAHO, the United Nations Fund for Population Activities, and more recently, the UN Office of Drugs and Crime, UNODC, which is based also in Vienna. in the same UN site as the INCB. And for the past 17 years, she's coordinated global programs for treatment of substance use disorders at UNODC. From 2020 to 2023, she served as the UNODC liaison officer at World Health Organization headquarters in Geneva. And in this role, she led collaborative UNODC and WHO efforts to reduce demand for illicit drugs. And she led the UNODC WHO program on drug dependence treatment and care. Since 2023, Dr. Sayens has led the UNODC program on access to controlled medicines for medical and scientific use and preventing diversion and abuse. So Dr. Sayens, thank you very much for joining us and helping us to understand barriers from the perspective of UNODC. Please.
Yeah. Thank you very much, Dr. Krakauer. Thank you very much, colleagues from the Harvard Medical School and the program on global palliative care. I just want to check, thank you for this invitation. Of course, it is a pleasure and an honor for me to have been invited and to be participating in this important event. I first want to check that you can see me, hear me, and that you can see my slides so that I can start.
Yes.
Thank you very much. So I tried, because I knew INCB colleagues are presenting and also WHO. I tried to prepare do my presentation based on the request that you made to me in terms of the content related to the mandate of UNODC. I have to say that some of your suggestions were very illustrating of what UNODC could do also in the future. So I even appreciate that. And I don't want, of course, to duplicate what my colleagues are going to be saying. So I hope that I managed to do it. So this is what UNODC does, or our role in the context of the International Drug Control System, together with the International Narcotics Control Board. UNODC is part of the International Drug Control System, also with WHO, and we serve as secretariat to two important bodies, the Commission of Narcotic Drugs and the INCB. But in addition to that, our main role is to collect data about drugs, about what happens in the world around drugs in general, but also support member states in complying with the commitments under international drug control system and the conventions which were already mentioned, the 61, the 71, and the 88. But
sorry to interrupt, Dr. Sayens. Could you click on the presentation mode, because we're seeing.
I can see my presentation moving. You cannot?
No, it's not the moving. Underneath the slide, there's a little icon of a screen with a line through it. If you could click on that, I think that's the one.
Yeah, but then I cannot see it now myself.
Yeah,
can you see it?
How do
Can you see?
Dr. Khadi, how do we help her put it into presentation mode?
I'm not sure exactly, but we're seeing your notes, Dr. Sayens, as well as the next slide. So if you're able to put it on presenter views, show view, so we're only seeing the slides and not your notes. Madeline, are you able to help out?
Oh, there,
Oh,
okay.
There we go. Perfect.
You got it?
Yes.
Yes.
Thank you.
Can you see it now?
Excellent. Yep. Thank you.
Okay, I am in the second slide now. Yeah, can you see International Drug Control System?
You're still in the first slide. There we go. Second slide.
Oh, yeah, click on the,
Perfect.
click there, yeah, there.
Something is very strange here, to be honest.
I think it's okay, yeah.
Okay, so the objective of the conventions is, of course, to protect the public health from the potential harms caused by illicit drugs. But the most noble objective of the convention, or goal of the conventions, is also to ensure that there are adequate supply of these medications, to prevent over-restrictive legislation, to make these medications available, and to make sure that they are also accessible to people who are in need of this medication. So this was the first. Can you see the change in my slides?
Yes, thank you.
Okay, so this was the first subtitle that you asked me to talk about: debunking misguided fear and misunderstanding of opioids. And of course, the first thing is, I don't think anyone can deny that controlled medicines in general have medical purposes, medical uses, and in particular morphine for the treatment of pain, not only cancer-related pain, but also other conditions like HIV, sickle cell disease, etc. But also in the healthy population, opioids, and especially morphine, can also are to be used to prevent pain from happening. Yeah, but we also know that untreated pain, when it persists, it becomes a health problem in itself and a disease in itself, creating huge burdens to the health system and so on. And unfortunately, despite the efforts of the international community, we still, and you mentioned that, Dr. Krakauer, we still see that the important issue of reaching out the balance between ensuring the availability and access versus preventing diversion, non-medical use, and misuse it's unattainable. It seems like despite the efforts, despite more than 10 years of this problem being put in the spotlight, the huge imbalances, like the colleague from INCB just showed, in access to controlled medicines, especially morphine, these efforts have not produced the desired outcome that we want. So I think one of the things that we cannot deny and we have to mention is the role of, or the narrative that has, and the impact that the narrative related to the opioid crisis in the US have had with regards to countries moving from over-restrictive measures, especially to prevent diversion of controlled medicines, versus their efforts to reach out that balance in ensuring the availability and access. And far from seeing a solution to the opioid crisis in the US, we constantly see new appearances, like the mixture of, what started with OxyContin, now it is the big problem is fentanyl, but beyond that, we see fentanyl being mixed with other very potent opioids. And then, of course, member states, including many countries in Europe, are sort of preparing or being very concerned about a similar situation happening in their countries. And as you can imagine, of course, they want to work with us in improving their policies, in having drug policies that do not create limitations in the availability and access. But the concerns of a situation like the one in the US is, of course, having a very negative impact in all those efforts. So in addition to that, we have clearly identified which are the barriers to availability and access to controlled medicines. They were also mentioned, I will somehow go through them. The insufficient knowledge and training of many of the health professionals, also somehow influenced by the fear and the concerns and the stigma associated with controlled medicines in general, and especially morphine, because of its association with end of life. The behavior of the health professionals, especially the fears of dependence and addiction, as well as diversion. Also mentioned in INCB, the inaccurate quantification of the needs, and the fact that quotas are estimated on previous use rather than on epidemiological patterns and real needs. Something that has not been mentioned is the capacity of health systems, is something that we cannot forget, because it's not only about flooding countries with controlled substances if the health systems are not capable of managing the amount of controlled substances that are eventually needed on the basis of epidemiological patterns. Of course, the regulations, countries still have very strict regulations. Some countries use the name Poisons Act to refer to controlled medicines legislation. And of course, all the registration, prohibition, and measures that prevent export and import and licensing on some of the substances. I also want to refer to the barriers that refer specifically to medical doctors, especially because of the work that I will talk in the end that we're trying to do from UNODC, is the attitudes of the doctors with regards to the conditions that require controlled medicines, in particular terminal cancer. The cumbersome prescription procedures that make doctors sometimes avoid prescribing these medications because they have to go through a lot of paperwork and justifications and so on and so forth. The fear of diversion, also because in some countries there are liabilities for doctors when the medicines are diverted. the fear mostly due to the misunderstanding or the lack of knowledge about dependence and addiction, and the stigma, which I have mentioned earlier. So in order to debunk all these beliefs, which you have asked me to do, I think that we need to go back to the core of the international conventions. Yeah. First of all, already in 1961, it was recognized that dependence and addiction is not only related to the substance. We know that opioids in particular have a potential to produce dependence, and that because of the tolerance that is developed very rapidly, people can get dependent. But not every person that uses opioids will get dependent or develop an addiction. That is the first thing to debunk. The second one is that for people to develop dependence and to develop addiction in particular, we know that there are a series of risks at the micro level. There are a series of risks and protective factors that somehow will determine who eventually, upon starting use of any of these controlled substances, especially opioids, is at risk or could more likely develop a dependence and an addiction or an addiction. And said this, it is important also to note that dependence can be treated, and so can addiction. So there is no justification for medical doctors to not prescribing opioids when are needed for the treatment of pain because of the fear of addiction. In any case, patients should be referred to addiction specialists, or coordination mechanism between prescribers of opioids and people managing drug use disorders should be promoted in the countries. But beyond that, we not only have the micro factors that influence the possibility of developing addiction, but we also have micro factors like socioeconomic conditions that, like poverty, lack of education, conflict, the fact that a country could be a producer or a country where there is a lot of trafficking, that influence and have the possibility of affecting the dynamics around the use or prescription and use of controlled substances. The second main concern that I want to debunk here, and you mentioned that, Dr. Krakauer, is the fear of diversion. And I know that UNODC has even been criticized because diversion should not be the main goal. Preventing diversion should not be the main goal. And it's true that most countries have focused their efforts in preventing diversion and non-medical use. But our rationale also within the program is that unless we support countries to address diversion, and not only for everybody not to prescribe because of diversion, then we are in a catch-22 situation. So when doctors can prescribe safely and confidently, because the system has ensured that there is little diversion, especially within the health system where most diversion happens, then doctors will be able, and probably we will manage to improve the access and availability of these substances. But then again, when we get this kind of news, and this is very fresh, it's a National Institute of Drug Addiction press release from 2 days ago, where there are all these seizures and all these news about huge amounts of fentanyl or fentanyl contaminating lots of fields, I have the feeling that all of our efforts to promote availability and access to controlled medicines go to waste, because this has a huge impact in the beliefs and the concerns of policymakers, of doctors, of pharmacists, and everybody who is involved in the supply chains and policy supply chains and in the prescription of controlled medicines. The third part of the presentation that you asked me to talk about, and this is the one I was referring when I said this gives us new ideas to work, is working with the police so that they get involved in the development of balanced drug policies. UNODC has had experience working with the police, especially in support of HIV prevention programs, specifically harm reduction programs, in which community-oriented policing and training of police officers seeks to foster this community and police collaboration in order to not only understand the situation of people who use drugs and who have drug use disorders, but also find collaborative solutions, working proactively, and above all, preventing the violation of human rights, especially of people who use drugs, people who are living with HIV and other conditions associated with injecting drug use. So some of the key strategies that colleagues working on harm reduction that involve the police or policing include police being trained to know their community, to work together with the community, to understand the dynamics of the community so that they become fosters or enablers or facilitators of people going to drug treatment services, for example, or receiving their harm reduction interventions. Also, police participating in partnership with civil society organizations, and overall engaging the police and the law enforcement in all the communication between users and between the drug treatment services. So my question when I read this request from you to cover in my presentation is, what can we do? What can we learn from harm reduction and apply in the context of controlled medicines? Can we transfer, and again, I don't mean by this that we will now bring the police to the hospitals, bring the police, no. It's about the police as a facilitator, maybe working with the communities where we know people have been prescribed controlled medicine so that they don't chase, they don't go after the people who are using controlled medicines. Then the third and last part that you asked me to talk is how scaling up harm reduction programs and treatment of drug use disorders can also facilitate the access and availability of opioids for medical use. And of course, UNODC and WHO, we work together for years promoting evidence-based drug treatment interventions. We know that treating drug use disorders is the best way to reduce demand for drugs. The least drugs are used, then the least mortality and morbidity associated with drug use, therefore least concerns about the medical use of controlled substances. And in the international standards, you can find all the settings and all the different therapeutic interventions that should be applied to manage drug use disorders. And in addition to the international standards, UNODC has worked for a long time as a co-sponsor of UNAIDS. And we also have a package of harm reduction interventions that are extremely important to reduce the associated harms, especially of injecting drug use. And I think that in the context of this list of interventions, and going back to the impact of the opioid overdose, of course, opioid overdose deaths prevention or opioid overdose prevention and reducing the number of deaths caused to opioids is an important component, because precisely the impact that opioid overdose deaths that now reach more than 500,000 only in the US is having on our efforts to increase the availability and access to controlled medicines. So in addition to harm reduction for HIV prevention and hepatitis C prevention, UNODC has developed and has been implementing together with the World Health Organization an initiative called the SOS, Stop Overdose Safely, which aims at reaching 90% goals of people trained to provide opioid overdose reversion naloxone, to train people on how to administer any potential witnesses of overdose, and also to carry naloxone with them, people who are injecting drugs. But beyond that, we know who are the people who are prone to have an opioid overdose. And these are not precisely the patients that have been prescribed morphine, for example, for the management of pain. So we need to be very clear in making that difference on who are the people who are dying of opioid overdose because they are illicitly or are using controlled medicines without medical prescription, versus the patients that genuinely receive a prescription because they have cancer, metastases, or they are in the late stages of cancer and receiving palliative care. So what are we doing in order to address some of these challenges? Well, we have established a network of young doctors precisely with the rationale that young doctors probably are more likely to understand what has happened in the 60 years of evolution of the drug control system and internalize and start changing their practices, their attitudes, and their beliefs around controlled medicines. Also to overcome some of the challenges that were mentioned also by my colleague in INCB, issues around working with pharmaceutical industry, working to, for example, increase the local production of medicines at affordable prices. So we have invited other UN agencies like the United Nations Industrial Development to support countries in developing their national pharmaceutical industry, making sure that controlled medicines are also included. The same with other agencies like UNFPA, UNDP, UNICEF, to tackle this issue from a multi-sectorial approach. We are also working on identifying what could be the appropriate tools. And I go back again, one of the ideas that came out of my participation today is that we would like to work more on engaging probably the police, and we have already make contact with some organizations like GLEFA, which is the Global Law Enforcement Public Health Initiative, to see how can we engage the police, not only in developing sound policies, but also in helping us with supporting efforts to increase the availability and access. And last but not least, we also understand that non-medical use and misuse of controlled medicines have an impact on the availability and access. And by proxy, we would like to address these two components or two pillars of our program to secure that there is adequate availability for people who really need these medications for the treatment of pain and for palliative care. And I think with this, I finish my presentation. Thank you very much.
Thank you so much, Dr. Sayans. This is, I think, what you just described, what you just spoke about, is absolutely essential to finding ways to reduce this unacceptable situation of lack of access, lack of safe access. And I think among the points you made, there are lots of possibilities, and I hope we can continue to discuss this, all of us among ourselves, and further refine or initiate concrete actions to improve the situation. There have been some very good questions in the chat and interesting responses, and I have many of my own, but before getting to the discussion, let's welcome our third and final speaker, Dr. Hugh Seong Teo. I hope I didn't mangle the pronunciation too much. Perfect. My friend Q from the World Health Organization. He is a technical officer in the Department of Essential Medicines and Health Products at WHO headquarters in Geneva. And if I understand correctly, Dr. Q, you've worked as a clinical pharmacist, as an academic health economist, and as a consultant to industry and governments. And at WHO, I know you've led work on pricing policies of health products. For example, the 2020 WHO guideline on country pharmaceutical pricing policies. And most recently, I know that you served as project lead and principal author of a very important WHO report that I would urge everyone to look at. It's available online, and it's called Left Behind in Pain: Extent and Causes of Global Variations in Access to Morphine for Medical Use and Actions to Improve Safe Access. If you look on your search engine with WHO and Left Behind in Pain, I'm sure you could find it. So we've heard now from INCB and from the UN Office of Drugs and Crime. How are we going to safely get morphine to the millions of patients who are suffering unnecessarily because they lack access? Help us out here, Dr. Keogh. How are we going to do that?
Thank you so much, Professor Krakauer, for that very generous introductions, and I'm delighted to join this distinguished panel. So before I do that, I would like to clarify that the views in this presentation and webinar are my own and does not necessarily represent the WHO position. So the organizers have given me two very difficult questions. How does WHO work to facilitate balance in national policies and practices to ensure safe access to opiates for medical use, and also how to ensure access to opiates in humanitarian emergencies, both very pertinent topics. So in a very short summary for a very complex question, WHO tried to perform its core functions by addressing these topics more broadly about access to essential medicines. The first core function is issuance of normative and technical guidance by presenting evidence-based guidelines, etc. The second core activities is to provide country support. This could, upon their request, so this could be providing capacity building activities, or even you will see in some of my slides, provisions of some medicines in certain specific contexts. The final but very important role is our convening role in making sure that stakeholders have convened and also building partnership with different stakeholders. So I will elaborate them in my presentation. So I think you have heard like 3 times about opiates belonging to this group of medicines which is controlled under international and national legal instruments. At the international levels, so there are 2 conventions that's most pertinent for them. The first one is the 1961 Single Convention on Narcotic Drugs, and then there is a 1971 on psychotropic substances, which is more pertinent for more broad range of palliative care medicines. The signatories to this convention then translate them into their national laws and regulations. So that's how I think that framework is very important to clarify. Both conventions emphasize the need to achieve balance. So you can see that even though the purpose is to limit possessions, consumptions, trade, and distributions, and import, export, manufacture, and productions of drugs to medical and scientific purposes, and also trying to fight against drug trafficking, in the preambles of both conventions emphasize the indispensable role of having access to these essential medicines for medical use and scientific purposes. So that means that in the national laws should also reflect the purpose of these conventions, as my colleagues from UNODC have highlighted, and INCB as well. So within WHO, we are also guided by work program given to us, from the World Health Assembly through resolution. So every May they will meet and then they give us some mandates to work on certain topics. So I've highlighted 3 kind of pertinent resolutions here. But of course, we also need to observe the covenants, resolutions, and principles endorsed by the UN Human Rights Council and UN General Assembly, such as human rights, universal health coverage, and primary health care and public health, with a focus on public health. So that's my very quick introductions about the context of WHO in the work of this area. So these are just some of the examples of WHO work in promoting safe access to opioids. So in terms of the normative and technical guidance, you can see that the first example here is a model guidelines for the international provision of controlled medicines for emergency medical care. The font is a bit faint, but it is an important document. It was published in 1996, but it's still very, very much relevant today, and it should be still applied by member states. There's also a more recent guidelines on for pharmacological and radiotherapeutic management of cancer pain in adults and adolescents. And then my colleagues are also in the process of updating a WHO guideline on ensuring balanced national policies for access and safe use of controlled medicines. In terms of country support under emergency and certain situations such as conflict or due to natural disasters, they do have some preset kits with controlled medicines, including opioids, in these kits. So there are a lot of details in these kits, so which I'm not a specialist in this, but my colleagues in the emergency departments, they manage the provision of this. So this includes the intra-agency emergency health kits, the trauma emergency surgical kits, pediatric kits. We also have some long-term agreements where we have bulk items, morphine, for people to be able to order them under these circumstances. We obviously conduct regional and country missions, trying to provide support to countries upon their request. In terms of the convening and partnership role, you have heard from my colleagues that we work quite closely sometimes with the different agencies. For example, during COVID, there's a joint statement on access to controlled medicines in emergencies. And then more formally, we have some committees on drug dependence. We also have some more formal agreements, UNODC, WHO program on drug dependence treatment and care. And then less formally, we have some working groups on palliative care, for which I think Professor Krakauer is the member of, and also we run some webinars. So these are really important partnerships because these are very complex topics that requires everyone to be on board. So I want to focus now on the report that Dr. Krakauer generously introduced. So last year we published this report called Left Behind in Pain. Unfortunately, this is a sobering title that reflects the status of the situation where we haven't really achieved the balance. So there are really, the introduction of the report highlighted two crises. So on one hand, we have access due to inappropriate and over prescription, combined with widespread availability of illicit, unregulated opioids, such as fentanyl, in some countries, and it's causing significant harms and loss of life. So I want to emphasize that these are illicit, unregulated opioids. These are not, in my understanding of the terms, diversions. So I think it's a really important qualification that we shouldn't confuse them with, like it goes to a medical facility, suddenly they flood the markets with all these medicines. So I know that these high-income countries are doing a lot of measures trying to mitigate these harms. The focus of the report is really on the other side of the coins, where we have very limited access to strong opiates such as morphine in many parts of the world. And this is where Dr. Krakauer coined them as insufferable pain. And this is a major crisis that we must tackle. So we focus on morphine because it's the most basic essential medicine. It has been listed in the first edition of both the model list of essential medicines at WHO. The first one is for adults, and the second one is for children. The morphine is also less expensive than other derivative and synthetic opioids, which have been associated with the opiate overdose epidemic in few high-income countries. So I won't go too much. I think we all know that there's a persistent lack of access to morphine for medical use. So in this Sankey chart, you can see that most of the opiums reported consumptions, or at least distributed quantity, is to North Americans and Europe, and in high-income countries. So this is a problem. This is the imbalance of the current situation. We also observe that the consumption patterns vary significantly across countries of similar wealth and does not correspond to medical needs. So on the horizontal axis, we use the data quantified by experts from the Lancet commissions a few years ago that look at the estimated number of days with moderate to severe pain or dyspnea per capita. And then on the vertical axis, that you look at the defined daily dose and that my colleagues has presented. You can see that high-income countries represented by the dots the blue dots at the top, and they're followed by the upper middle-income countries, the lower middle-income countries, and the low-income countries at the bottom. But even across the horizontals, you can see there's significant variations. We don't know what drives this, like variations, even though there seems to have the same estimated medical needs. So we must better understand what is driving these differences in terms of the consumptions. Given that pain, especially strong pain, I would say that it's a universal human experience. We also observed that lower-income countries are much more dependent on morphine to meet the medical needs of their population. So this chart shows the proportion of morphine to the total consumptions of opioids. So you can see that lower-income countries, some of them exclusively or more than 75% of their consumption relies on morphine, despite the very minimal amounts in these countries. So what it means is that when there's a disruption in supply or when there's significant restrictions in terms of strict shipments, people are going to suffer. We must secure the supply chain and making sure that the supply is coordinated. I won't go into too much details about the enablers and barriers, so in the interest of time, but I want to emphasize that sometimes they are often the two sides of the same coin. So we want to emphasize good governance. We want good regulations and policies, but when there are too much, it can become a bit of a barrier for access. Similarly, where we need adequate resources, we need to have predictable, stable, and adequate funding for medicines, essential medicines such as morphine. When when we don't have them, then it means that there are irregular availability, and then people are not sure where to get them, or they're unaffordable when they arrive. And then, some of the geographical barriers can also present barriers to access. And then finally, the third column is about the sufficient capacity. We want to build them, but when we have the negative attitudes as highlighted by my colleagues from UNODC, it can actually present a bit of issues in providing them more effectively. This is a very busy slide that I don't expect you to read, but it's in the report. So the report ran a survey of member states. So we asked people to rank the different measures grouped by access, governance, skill set, awareness, and resourcing. I want to emphasize the needs to make sure that the health systems is very complex, and we know that health system is very different in different countries. Even though there are some universal principles that we can promote, but this must be led by the country. So we must find, we must advocate the government to take lead in solving these access issues from their side, based on their understanding of the different ways to do things. So that's all I wanted to say. And health and human rights must be at the center of all policy. I want to come back to the topics of balance. These are my final slides. So we understand the concerns about potential harmful effects of opiates. They are often valid. And for this reason, certain amount of caution about potential harms of opiates is good for public health insofar as it is well-informed and proportionate to risk. But this is a quote from the report, we must make sure that such concerns does not undermine the benefits of opioid use when they are clinically indicated and used safely by trained professionals. And this is a key message that we will remind country policymakers to repeat to them at every event that we will do. And then, and also we must recognize that behind all the statistics and all the statements, there are human voices. So we have developed 3 very short films, trying to making sure that people understand what it actually means to people who are affected by access. So the first one is the family members of someone who suffered from cancer at the end of his life. And then the second one is the clinicians who have access to use them and know how to use them. And the third one is the country program from Uganda, where they have a local program to develop oral liquid morphine. So I will suggest that they are on YouTube. I'll suggest people to propagate like this film, remind people that policies actually impact people. And I would like to leave you with the statements from my Assistant Director General. I won't read them, but basically she's saying that we need to urgently access everywhere. So with that, I will conclude my presentation. Thank you very much.
Thank you so much, Dr. Q. At the end there, at least for me, your voice was breaking up a little bit, and we'd really like to be able to hear you in our discussion, which will begin now. And thanks to all those who've submitted questions and comments, and we'll need to check with, to confirm with all of our speakers if they agree to share their slides with the participants, and if so, we'll try to get those, make those available, because these are really, really important slides that include information that a lot of information that I didn't know, and may benefit a lot of our colleagues around the world who are listening in and who are working on this problem. So again, thank you, Dr. Sayens. Dr. Sayens has kindly agreed. I want to go back, if I could, to begin the discussion, to something that you said in your presentation, Dr. Sayens, about working with the police. I'm convinced that as much as WHO is doing, and the INCB and the Commission on Narcotic Drugs, if we're going to get solutions, if we're going to get the medicines safely to the people who need them, it's going to take involvement by the UNODC and by the ministries of police. So I'm wondering, you in your comments about community-oriented policing, which was used during to help prevent HIV, and about harm reduction, and how that might also help to reduce fear of opioid analgesia. I'm wondering if UNODC either has or might produce a statement specifically for ministries of police on encouraging pain management and harm reduction, and on basically to recommend that ministries of police state clearly that they do not stand in the way of legitimate prescribing and treatment of pain, and in fact that maybe they even encourage effective pain treatment according to international guidelines, because for one thing, as was stated by Professor Zingela, I think pain, or also by you, Dr. Sayens, unrelieved pain has enormous costs, not only for patients, but also for countries' economies, because it's devastating and unnecessarily so. So could the UNODC issue a stronger statement, perhaps with support from other UN agencies or from civil society, to encourage ministries of police to state more clearly that they do not stand in the way in any way in pain, in the way of pain treatment and pain relief, and in fact encourage it?
Yeah. Thank you, Dr. Krakauer, and thank you for the audience for the questions. Well, as I said before, at the moment, we don't have a program that addresses prescribed medicines, yeah, and looking at the role that the police could have to, especially to not see patients, or even, let's assume the possibility or the case of a medicine that has leaked from a patient to a community, for example, something that can happen. So how should the police react in these circumstances so that the patient who has been prescribed its medicine and is using it legitimately is not affected by a police reaction? I think that we have a lot to learn from what colleagues have been doing, working with law enforcement, to sensitize them, to train them, to work with the communities, to work with the drug treatment services, to harm reduction, social workers, etc., so that particularly people who use drugs, people who inject drugs that are the target of harm reduction interventions, are not chased by the police, that they are not around drug treatment services, you know, waiting for drug users to come to the services to take them to prisons. So how could we use those positive experiences to maybe apply, and maybe this is something that we can work together with those of you who have experience prescribing these medicines, and with the patients and with the communities. What are the daily experiences they have of people who are carrying morphine, yeah, and maybe are stopped in the public transport? Because remember, the control of medicine stop at distribution. So once the patient has the medicine, or sometimes it's the pharmacy, in reality, knowing what happens with the medicine is not always 100% accurate. Yeah. So maybe we can engage these actors, the patients, the communities, the law enforcement, to also become enablers. I think that this is something that can be done. I wanted to clarify something, because Dr. Q, he said it, and it's very true. When I talked about the impact, is the impact of all this news about fentanyl, which is definitely not official. is the impact that this has on the reaction of policymakers, yeah? Because, and they also in doctors, you know, because sometimes they don't want to prescribe fentanyl, for example, because of the concerns about all the news that they read in the media, etc. But yeah, Dr. Krakauer, I think that with palliative groups, we could think together about the role of police, law enforcement, how to influence policy. And in fact, we have been in contact not only with GLEFA, but also with the Behavioral Health Foundation. And they have, in the US, they have worked not at federal level, but in some states, work on developing some toolkits for patients. And they are also working on addressing the media and how the media should use language that is not affecting the patients and the people that are in possession of controlled medicines because they have been legitimately prescribed.
Thank you. Thank you. Yeah, I think there's really, this is a very important avenue, and your idea to have collaboration between UNODC and some of the global or regional palliative care organizations, or I would add even the pain organizations like the International Association for Study of Pain. Perhaps there could be important collaboration there. If I could follow up on what you were saying, and this is based on a question from Dr. Jung in the chat from Vietnam, either for Dr. Kyo or Dr. Sayens, is there guidance also on avoiding diversion in healthcare settings? And a particular problem that that I see in places where I work, in the home. So if a patient is receiving opioid or morphine therapy for pain and is at home, if the pain is relieved either because chemotherapy is working and the pain is less, or if the patient dies and there is leftover opioids, especially where there's a black market and where people are very poor, there's an incentive to then sell the medicines on the black market. So, you know, in the hospital, there is some diversion, but in the community, there's even more. How can we minimize those risks? What can be done to, and is there already guidance on avoiding diversion in healthcare settings and in the home?
Yeah, I don't know if Q, you want to respond about, because I have. Yeah, well, precisely in October this year, we have sent a request for countries to nominate experts. We're going to have the first meeting on addressing diversion of controlled medicines, mostly in the health system, because we don't have such guidance. That's the answer, the concrete answer. We know that diversion happens a lot in the health system. And I want to clarify, our idea is precisely not to bring the police to the health services, is not to focus on the prosecution of people who have been involved in diverting controlled medicines, but rather on capacity building, sensitization, awareness raising of all the people that are involved that could potentially facilitate diversion within the health system. And health system is very broad. And remember that for diversion to happen in the health system, we also have important phenomena that can be implicated, like corruption, organized crime, the theft of medicines, and also linkages to falsified medicines within the health system. So how to approach all those complex issues within the health system to prevent diversion. The second component that we are addressing is misuse, and you gave the example. Remember, non-medical use refers to people who do not have a prescription of a controlled medicine and get it through the illicit markets and use it. Whilst misuse is the people who have a prescription, but they decide to use it otherwise. And that includes the people, for example, that shorten the duration of the treatment or reduce the dosage. And then we have the problem of the leftovers, for example. So any medication that is not used properly as recommended by the doctor and stays in a bathroom cabinet, for example, is a risk for diversion of this medicine or the non-medical use by somebody else. So in addressing diversion, we also want to talk about, for example, disposal mechanisms. What are countries doing with unused medications? We know of experiences in the US that look at, collection in pharmacies or collection points, etc. But it's also a burden, for the pharmacies, because they need to ensure the safety of unused medicines. They need to, know where to dispose. They need a space, which in many countries costs a lot of money, etc., and so on and so forth. So these are complex issues. In October, we will be addressing, and the idea is to develop two things: the guidance that the person was, hopefully we will have it by the end of this year, and the second is training materials. So we need to know who needs to be trained on doing what, so that we can prevent diversion in the health system.
So I'd like to, so for me, I think having clarity about the magnitude of diversion, if it ever exists, is important. I think, but just by saying that it's a lot, it happens a lot, doesn't help, like in terms of our attempt to formulate targeted response. So the second point that I want to raise is that the diversions of controlled medicines relative to other non-controlled medicines. So I'm aware that some high-cost medicines are being diverted because these are criminal activities. There are money to be made. Say, for example, I'm aware that cancer medicines have been diverted so that people can actually earn money in the market. So they sell it, in some unregulated channels. So I think if we were to have some productive discussions, having those very precise statistics so that we don't actually cloud the discussions by saying that it happens a lot, when in fact, the evidence that I at least for myself, I haven't really seen a very compelling data to show me that, like to the extent to which, diversion actually happens. I think that's the first point that I want to make. And secondly, I think if diversions were to happen, of course, like countries already have existing many measures trying to prevent diversions. So one of my colleagues actually shared her experience of visiting a health facilities in a country where, like she actually essentially has to walk into a room that looks like a prison with all the rail, in order the pharmacists have to be in that room in order to access morphine and controlled substances. So this is the extent to which people are so fearful of these medicines, rather than having the confidence that the system is well built to prevent the so-called, it's almost like an imaginary diversions, when in fact like the legal activities is still happening like outside of the prison. In fact, very sadly, some of my, in one of the webinars that we have heard previously, some of the country experts share their experiences with us that they actually have to refer their patients to the black market to have access to some medicines, controlled medicines. I think that's obviously a deficiency of the health system because you have no control over it. So I think, so what she's trying to say is that the regulation is so restrictive to the extent that people have to resort to such measure to have access to them, even though there's no visibility of the quality of the medicines and the sources of the medicines as well. So I think we must put ourselves in the right perspective, backed by evidence and data, and try to formulate the right policy response to them. So I'll pause there. Thank you.
Thank you, Dr. Q. Again, if we have a few minutes left, if you have questions or comments, please put them in the chat. Professor Zingela had to leave, but she put some comments in the chat. And one comment was her encouragement for pooled purchasing. And this is something that I've thought for many years could be an important part of the solution and was very effective for making accessible at a very low price medicines, second-line medicines for drug-resistant tuberculosis. And the idea is that even where demand is not very high, or the estimates of need are not very high from an individual country, especially a small country, if there could be purchasing groups, for example, if Francophone African countries or East African countries were able to pool their demand for morphine and thereby have more leverage to negotiate better prices to obtain either the finished products or morphine powder. Pooled purchasing groups could be part of the answer. And she also mentioned the importance of training, not just for healthcare providers, but for healthcare officials. Many officials do not know about the Single Convention on Narcotic Drugs. They don't know about the various documents of UNODC and WHO and INCB. So the importance of training for officials. But I would also like to ask both Dr. There's a lot of noise. If you could mute your microphones, or Madeline, if you could mute the microphones, thanks. I'd like to address a question both to Dr. Q and Dr. Sayens again, and this is about accessibility of morphine and controlled medicines in humanitarian settings. Unfortunately, we know that there are horrible humanitarian crises going on in multiple places in the world. And my understanding from both from publications and from humanitarian responders is that the kits that you mentioned, Dr. Q, the kits that contain morphine, that contain controlled medicines, often are not being ordered because of fear that they'll be held up at the border and then none of the contents will get into the country. And therefore, the kits that are being ordered are the ones that do not contain controlled medicines. Now, you very appropriately showed, I believe it was the policy from 1996 of WHO on making controlled medicines, including morphine, accessible in humanitarian settings. But, and I think it's very well done, it's just not working. So what can be done to make this, to resolve this problem that, that the kits which contain morphine, which is so important, especially in humanitarian settings, both for people with traumatic injuries and for people with chronic illness who've lost access to healthcare in humanitarian settings. What can be done to assure that the kits that contain morphine can be made safely accessible in humanitarian settings? Thanks.
I must first, declare that I'm actually not involved in the day-to-day operations of those kits. So, but what I can tell you is that based on my understanding, having my discussions with my colleagues at Médecins Sans Frontières, ICSRC, and even within WHO, these are very complex situations which evolved, over time, and they are also from the legal perspective, for example, the lack of recognized country authorities, like the lack of awareness of the border, officers, for example, anything can actually delay access to some essential medicines. So my understanding is that they are working very closely just to make sure that some of these controlled medicines are provided. So they work under extreme difficult circumstances that requires a lot of negotiations, a lot of awareness, and also my colleagues at INCB also provided some support in terms of clarifying the international rules and also trying to engage with the focal points. So that's all I could provide you with information. The situation that you described, Dr. Krakauer, it is correct. Like these are sometimes they have to withhold the modules that contain controlled medicines, so that it doesn't actually delay the shipments of other essential medicines, which can happen. Yeah. So in terms of how we resolve this, I think like the continuous engagement with the country officers, I think is important. So.
Yeah, so in working on this problem, it's the regulations that should allow the importation of controlled medicines for emergency purposes are very well written, but people aren't aware of them. The Ministry of Health officials are in crisis mode when there's a crisis, and the customs officers at the borders are not aware, don't know all these details. So I think that yeah, that more work needs to be done to figure this out. But what I in our last couple of minutes, I think that what's been presented here today is extremely important, and I think it's really crucial for the sake of those suffering unnecessarily around the world that we don't end this discussion here. I think that a lot of really important points could be made, and I'd like to have been made, and I'd like to propose, perhaps as a next step, that that the speakers and our three organizations and also some of the civil society organizations, our group here at Harvard, and perhaps some of the palliative care or pain organizations, work together first to lay out the problems in a very clear way, so that it becomes more clear what we're dealing with, and in that way then also decide where to focus efforts and what are the most important ways to proceed, which barriers to work on. So again, I hope this is just a beginning. So I want to thank you so much for taking so much time during your busy days. And I look forward to working much more with you. Dr. Kiu at WHO, Dr. Sayens at the UN Office of Drugs and Crime, and Professor Zingela, and also the Secretariat, including Dr. Stefano Betterame at the INCB. Look forward to collaborating much more in the future. We must solve this problem. Thanks to all those who joined us, and let's keep working. Thanks so much to everyone.
Thank you very much.
Thank you very much for organizing this.
Thank
Goodbye.
you very much for inviting us.